Okay, great, excellent. Good afternoon, everyone. And many thanks, Paula, for organizing this webinar session entitled ENT Problems in Children. I always like to have this interaction with my primary care colleagues, which I think is very essential for the benefit of our patients. Um, I will give a bit of background for me. I'm one of the ENT head and neck and thyroid consultant working at Queen's Hospital. I was appointed in 2016. I'm also clinical lead in pediatrics ENT at Queen's Hospital, Romford. This is a picture of our hospital. I'll give a bit of background. I initially graduated from India, Delhi, did my master's in ENT with a research-based thesis, and did registrarship prior to coming to UK, where I went through the training system again and completed my training with the MSc, which was awarded with a research-based thesis from Warwick University. I completed my exit exam, and my key jobs included the pediatric ENT fellowship at Evelina Children's Hospital at St. Thomas, and 1 year I spent at Head and Neck Centre, University College Hospital, London, where I worked as senior registrar. Um, and I've been a substantive consultant at Queen's Hospital, Romford for the last 5 years. So there's just a few pictures of the Evelina Children's Hospital, lovely location in South Banks, state-of-the-art art hospital with very good pediatric ENT department with airway facilities and pretty much do everything. So I learned a lot during my stay at Evelina Children's Hospital. And this is the UCL edge. I'm going to divide my talk into three different areas, of course, ear, nose, and throat. And as Bola said, if you can note down the questions you might have, either write in the chat box or on a piece of paper, and feel free to ask at the end, and I'll be able to answer questions if you just write a message in the chat box. I'll start off with tongue tie, or encologlosia, as it's often called. Tongue tie is not uncommon condition, obviously going by age. So this is the first thing you would encounter in pediatrics. Soon after the child is born, it's often the midwives who point it out. Um, the incidence is 1 in 10, so 10%. Is more common in boys, but is also present in girls. I'm one of the recognized tongue tie practitioner and listed on ATP website. Um, Basically, as GP, soon after the birth, the kids, its usual story is the parents will, the midwife will point it out to the parents that the kid is having a tongue tie. The type of problems it can cause is feeding problems at birth, most common latching onto the breast, causing painful nipples and sore mastitis. Um, the child might take a long time to feed. Might if it doesn't get enough milk, obviously there can be failure to thrive, which you can. The mom might present to you as a GP because he's not putting on weight. That might be reflected in the red book. He's never satisfied. He's always hungry. Mom might consult herself with the sore and damaged nipples, which is associated often with tongue tie. There are two different types of tongue ties: anterior or posterior. Anterior is more easier to diagnose as compared to posterior. Um, So first of all, I see a lot of these patients referred to me at Queens as well as outside. The assessment of tongue tie and its succeeding, it's quite a severe tongue tie can be quite a condition which can have profound adverse effects on the child well-being with regards to feeding and thriving. And the assessment is simple, is undertaken in the clinic. I usually, there is a pediatric nurse with me. We swaddle the child, have a look, assess the side-to-side tongue movement, tongue protrusion. Usually, the age group of children presenting to me with this problem is within the first few weeks or months of birth. The earliest I've done a tongue tie excision in clinic is 1 day old child, and the eldest, all the older, obviously in general, Assessment and excision both takes only a few minutes. It's like a haircut, so it doesn't hurt. So it can be done without local anesthetic in clinic. The sooner the child presents for assessment, the better, because for the first 6 months, they're performed in clinic without anesthesia, as you would see from the slide. From 6 to 12 months, it's both more of a gray area whereby I'll have to assess the child in a more active and or stronger child. They might have to be done under GA, but the most older child I've done in clinic is 1 year old. So it depends a lot on the child and the parents if they're happy to have it done. It's important to explain to them that it's like a haircut, so it doesn't hurt. Child might still cry because they might not like me shoving scissors in their mouth and stuff like that. Um, Over 1 year old children in general, if they present with a tongue tie causing significant problem with feeding, they will need it oxygen under general anesthesia. Apart from feeding issues, in case of a severe tongue tie, it can also cause pronunciation problems, especially of the words like th and la, which requires a tongue to touch at the top of your mouth. Um, so excision is quite straightforward procedure, takes few seconds, and baby can be breastfed straight afterwards. Um, Out of the children who have tongue tie, in my experience, about 50% require tongue tie excision, and rest 50% I just reassured the parents. So this is our tongue tie. Epistaxis, of course. All of us at some point or other, and I'm sure in your surgeries you would have seen young kids with epistaxis, nasal bleeds. And most common issues in a younger child is they get runny nose as a part of growing up. They go to nursery, they go to school, they come in contact with other children, they pick up bugs, get runny nose. Um, this in the dry cold weather, this nose, the discharge dries up from bogies. It causes irritation and inflammation. So often child might be actually tempted to scratch it, or even otherwise it causes a proliferation of blood vessels and the crust come off, often causing bleeding. So that's how the it happens. The key is moisturizing the nose. All of us are aware of saline nasal spray Sterimar, which is popularly available freely over the counter. You can use the spray or drops, even saline nasal drops, which would help with um, clearance of this nasal discharge or bogies or dry crust, reducing the inflammation as well. Um, Septin nasal cream is another cream which not only helps to lubricate the nose but also reduces the inflammation. It has a steroid. It's always useful to ascertain that the child is not allergic to peanuts because it has peanut oil as well. In children with peanut allergy, the other option is mupirocin Bactroban nasal ointment, which does not have peanut oil. In the ENT UK website, I usually what I do, and this is something you could do in your surgeries as well, very useful resource. ENT UK website, go on the patient information leaflet. There are plenty of useful leaflets for free to download for patients or to any. I usually tend to print out a leaflet and give it to the patient. And one of the leaflet is on epistaxis. And you can advise the patients what to do, but it is a standardized leaflet which must be given to patients for advice. Um, Simple advice I give to patient is sit forward. I explain to them there's two parts of the nose. The top part is the bony part which you can't pitch. The bottom part is the soft part which you pitch the nose for 4 to 5 minutes. And the reason I say 5 minutes, as we know, is the bleeding time 4 minutes, 1 to 4 minutes. So the nose should be pinched for more than the bleeding time. So for 5 minutes at the very least, for the body's coagulation system to take its own effect. I advise them to get the child to suck a piece of ice and put some ice packs on the forehead. The idea is from top and bottom to cause the cold to constrict the blood vessels and hence to help with stop bleeding. I advise them against giving any warm food or hot drinks to child. If you can, so examine it, then you examine it, of course. If there is most common cause is a prominent blood vessels in the little's area and the nasal septum, which can quite easily be cauterized. In the clinic, with local anesthetic spray with silver nitrate cauteristic. Um, One of the caveats of epistaxis is the age group. In teenagers over 10 years of age, if it is a history of unilateral, persistent, recurrent, severe nasal bleeds, of course, they need a fiber optic nasal endoscopic examination to rule out nasopharyngeal angiofibroma, which is usually present in teenagers. So, and anyone over 10, I would consider that option. I'll do a fiber optic nasal endoscopic examination um, to rule this out, basically. Um, Also, the cases of recurrent nasal bleed, if they keep on presenting, it's useful to do a full blood count, coagulation profile, and blood films to rule out any bleeding diathesis, etc. Family history and tendency to bleed easily may require blood test, as I mentioned. So this is about epistaxis. So points to take home is epistaxis information leaflet on ENT UK website, very useful resource. Naseptin nasal cream, check they're not allergic to peanuts. Moisturize, advice in the form of leaflet. Cautery, that's for us to do, or community ENT clinics can do cautery as well. I'm not sure if there might be some specialist GP doing cautery in their own surgeries as well. And of course, in a teenager, rule out, do a nasal endoscope to rule out nasal naropharyngeal angiofibroma. Now, this is the bread and butter of ENT, really, recurrent tonsillar infection. Very common in kids. The usual stuff, I'm sure you would have seen lots of kids who keep, some kids often probably keep on representing to your surgery with history of throat pain, difficulty in swallowing, high temperature, bad smell, causing social embarrassment. So there are three different reasons whereby I see, in a specialist ENT consultant clinic, children with in relation to tonsil. One is where they keep on having recurrent tonsillar infection. Now, the question is who gets tonsillectomy on NHS and who does not? And in the past, it used to be a discussion, a history by the ENT consultant with the patient. And if I feel that they would benefit from it, I would list them. However, things have changed, and now there are SIGN guidelines, Scottish Intercollegiate Guideline Network guidelines, which says that anyone having well documented episodes of 7 or more episodes of tonsillitis in a year, or 5 or more episodes of recurrent tonsillitis in a year for 2 consecutive years, or 3 or more episodes of severe episodes of tonsillitis in a year for 3 consecutive years, would confirm can be referred for tonsillectomy under NHS. So obviously, in my experience, there is a wide variation in different CCGs and approval for funding, and whereby in some of the CCGs, a patient, if he reports about these, if the reports and by their history, if they confirm the criteria, that they will be admissible. Some of the CCs are much more stricter. So that is one of the criteria. Obviously, it's a bit of subjectivity to it. So let's say if someone is having very severe episodes, but just 6 episodes, they will have to wait. They can't have tonsillectomy on NHS. The second reason why, and I will actually refer to a different slide. So I get see patient is adenoid and tonsillar enlargement with snoring or sleep apnea. So as you can see in the picture, the very large obstructive tonsil. Often the patient present with video evidence where the child is snoring and obstructing at night. This reduces oxygen level in the blood and can cause disturbed sleep. This can affect child's behavior, and often they are referred. You would see that in these children they are referred for ADHD, or they're investigated for autistic spectrum disorder just because of their lack of concentration and behavioral issues, which might be linked to this obstructive sleep apnea. Video evidence is really helpful because you can see that the accessory, there is a tracheal tug or accessory muscles of respiration is working or the child is obstructing. Um, you can do a sleep studies. However, clinical history and video evidence is more helpful than sleep studies, just because sleep studies can vary widely. So if a child is having a bit of mild viral infection and the tonsils swell up, you can have absolutely horrendous sleep studies with severe sleep apnea. On another day, when the viral infection is resolved, the sleep studies can be completely normal. So I think careful history, parental feedback, and video evidence is more important um, than sleep studies, in my opinion. And that's what the standard practice at Evelina, where I did my fellowship. I said three reasons why children with tonsillitis with tonsil is. So I've discussed two. The third one, sorry, I'm trying to go back. Yeah. So the third one is tonsillar stones. So child does not have any obstructive sleep apnea. Child does not have any recurrent tonsillitis. They say, "Oh, I get this tonsillar stone, this horrible debris. It makes awful smell, and I've done everything." Believe it or not, one patient came to me and told me on Amazon you could get a tonsillar stone removal kit, and she was trying that, but she was absolutely fed up. Most of these people who come to me with a tonsillar stone complaints of irritation, social embarrassment caused by the halitosis. They usually would have tried everything, including cotton buds and brush, and they try and remove the stones. They often cause bleeding or inflammation of the tonsils. They would have tried gargles. So the usual thing in this is try gargle, etc. If this continue to have it is causing social problems, then tonsillectomy is the recommended option, really, because if they've tried everything else, they continue to have this problem. Tonsil in general are cryptic, so they have little crypts. One of the crypt is deepest, which is called crypta magna, and any food particles, any dead cells, any bacteria can lodge there and cause infection, halitosis. Usually, everyone doesn't have this problem, of course, but some people have it more than others. Of course, the treatment for tonsillitis, as you know, is antibiotic, antiseptic gargles, analgesia. One of the things I'd mention, especially more so relevant in the current pandemic, is if the initial aim in the first lockdown was to try and send as many patients as home and avoid to admit them. And one of the things we found quite useful is, in addition to antibiotics and analgesia, to give them steroid, which would help reduce the size of under the cover of antibiotic, which would reduce the size of tonsils and help with the recovery. So it's something we should consider. Maybe not in very young kids. Childhood nasal blockage and runny nose. All of us would have seen some children, quite often very young, 1 or 2 years. Mom comes and says, absolutely distressed. The child every night he's snotty all the time. He's running nose. He can't sleep. He snores. I'm absolutely at the end of my tether. What should I do? So it's nasal blockage is usually caused by two reasons. Posteriorly, as you can imagine, the adenoids can block. So the enlarged adenoids can block the nose from behind. In the front, these are the turbinates and the lining of the nose. If they swell up, which is often the case in kids by viral infection, or if they're allergic to something, that can cause blockage as well. So both the things are important and should be considered. The runny nose is often caused by either allergy, like if they have hay fever, or more likely if they pick up bugs very commonly and frequently, going to nursery or coming into contact with other kids, and then that can cause runny nose as well. This can have a adverse effect on their life and routine, cause sleep disturbance, snoring, or disruption of routine studies. If it is quite significant and cause obstructive apnea, children might be that might trigger off investigation for ADHD or autistic spectrum disorder. So quite might have quite profound effect in a child. Repeated sniffling, again, some patients come and say, oh, she's just doing snorting all the time, which is embarrassing in the classroom. We've had some reports from teachers, and that's what trigger off the referral to the clinic. Treatment is medical saline, medical saline and steroid nasal spray. So again, it has to be age appropriated. Anyone 3 or over, you can give Nasonex nasal spray, mometasone nasal spray, 50 microgram once during night time for a couple of months or so. Anyone 2 years or above, there is a it's not licensed, but there is in BNF, you would see there's a non-licensed use whereby you could give Nasacort nasal spray, triamcinolone acetonide, but that is licensed kids over 6-year-old, but this is non-licensed use, which if you're prescribing, and the parents need to be told about it to ensure they're happy. You can always give betnesol nasal drops for 10 days or so. It's ironic because the age limit is not specified, so you can prescribe it, although the absorption of steroids is more in nasal drops as compared to nasal spray. Obviously, if the problem persists in spite of the conservative measures, of course, in these runny mycopurulent rhinorrhea, you always use sterimar nasal spray. The chances are the parent would be using that already, and still kids is having problem. That's why they come to see you. So steroid nasal spray, antihistaminic like cetirizine syrup, age appropriate, it's quite helpful. Try that for a couple of months. If it does not help, and if the adenoids and or turbinates are large, then it will require surgical management. And the key here is to ensure that you treat the whole cause of nasal obstruction. So let's say in someone, I've seen cases whereby uh, adenodectomy is being performed in a child, but they still have nasal blockage, and that's because the turbinate were massively enlarged, which are not addressed at the same time. So it's useful to just check both turbinate and adenoids and do appropriate operation. So in this case, adenoidectomy and turbinate reduction both by nasal cautery to the turbinates. We already discussed this. So I was quite fortunate to learn this new technique, coblation intracapsular tonsillectomy and adenoidectomy, using the coblation device as shown in the figure at Evelina Children's Hospital, where they have come out with the biggest series of 1,000 kids undergoing these problems with adenotonsillectomy. The idea is you leave the capsule, which is the watershed line, and shave down and remove 95% of the tonsils, leaving the capsule with a sliver of tonsillar tissue behind. The idea is all the nerve endings are lateral to the capsule and bigger blood vessels are lateral to the capsule. So it has quicker recovery with less chances of bleeding post-op. In Evelina series, there was the risk of bleeding was 0.4%. I did a small series of my own at Queens, and none of the kids actually came back with bleeding. So it's quite a useful technique, especially in younger kids where the risk of bleeding can be more dangerous. Um, there is a downside though, because you're leaving a sliver of tissue behind. There is 3 to 4% chance that the tonsils can theoretically grow back, and if they grow back enough, to cause sleep apnea or clinical problems, then there is 3 to 4% chance, as published in the literature, they might require tonsillectomy again. Usually that's not a problem, because even if the tonsils grow, the kid grows with them as well. So there is always a bit of more space, but something to keep in mind. Coming on to the neck lumps. Now, neck lumps can be inflammatory, infective, developmental. Quite often, I'm sure you would have seen kids where parents are concerned, they have they have frequent sore throats, etc. And doctor, there is a lymph gland. It's been there for the last 1 year. I'm a bit worried. Can you, do something about it? What should we do? For persistent lymph glands in the neck, they're quite common in children, especially because they get sore throats, etc. The lymph glands come up after it's resolved. It should go down. It doesn't always, because they got thin necks and any lymph glands can be easily palpable. All you need is an ultrasound scan of the neck by consultant radiologist or sonographer who can give advice as to. And most of the kids in my experience, it turns out to be reactive, in which case only the parents only require reassurance that, oh, look, ultrasound scan has suggested the ecotexture is reactive, so you just need to keep an eye on it, don't need to worry about it. I generally do, in cases of persistent lymph glands, I generally, it's recommended to do a battery of immunoglobulin test for Bartonella, Epstein-Barr virus, cytomegalovirus, and toxoplasmosis. Realistically, I always do them, and sometimes, most of the time they come back negative, sometimes one or more immunoglobulins for this virus will come back as positive. And in that case, I've gone back to my colleagues in microbiology, and they always say that if the child is clinically well, nothing needs to be done. So I sometimes wonder what's the point of doing this blood test. But in any case, we always do this blood test. The other cyst, as you would have seen children with branchial or thyroglossal cyst. So thyroglossal cyst is a common developmental cyst. It is a developmental cyst of the thyroglossal tract, which is formed by in utero, basically. When the thyroid gland is being formed, it extends from foramen cecum at the base of tongue and goes down, as is highlighted in this picture, and comes in close relation to hyoid bone and then goes down and rests in the isthmus of thyroid gland, basically anywhere in the thyroglossal tract. Usually, in most cases, it resolves, it kind of obliterates, but sometimes there is a cyst which can be left anywhere in the thyroglossal tract. And the usual presentation is a picture like this: a midline anterior neck lump, which sometimes can get painful and swollen, get infected. Clinically, if you examine and ask the child to swallow, it will move up. And also, if you ask them to protrude the tongue out, it will move up as well, just because it's attached to the foramen cecum in the base of tongue. It can either come in front of the hyoid bone, it can track behind the hyoid bone, or sometimes, rarely, it can go through the hyoid bone as well. So, treatment, investigations, ultrasound scan, plus minus FNAC, depends on how big the child is. If it causes enough problem, the options are either to leave it as it is, or if it, by the time parents are referred to see, the chances are that it's causing enough problem. That's why they've been referred. Is a surgical treatment by Sistram's procedure, in which you remove, by an operation, remove this lump and part of the hyoid bone as well, which massively reduces the chances of recurrence. Because if you just remove the lump, and if it is going through the hyoid bone or very close relation to hyoid bone, and you haven't removed that, then it can always come back. So Sistram's procedure is the procedure of choice for this. Of course, these are more extreme neck lumps. This is cystic hygroma in a young child. This is again could be a thyroglossal cyst. Branchial cyst you often see in kids, which is present more typically on the lateral part of the neck in relation to the sternocleidomastoid muscle, usually upper 1/3 or middle 1/3, and present at the anterior border. Again, if it causes any problem, you can excise them. Again, this is second branchial cleft cysts. Now, this is one of the very important slides. It's probably, if there's one thing you want to take away from the talk there, please consider this in young child or bigger children. is silent reflux, and its importance. It's also very important in adults, but today we are talking about children. So quite often, I've seen like bigger children presenting with a bit of sore throat. I have to clear my throat all the time. I feel a sensation of lump. That is something is there. Throat feels a bit raw, bit of discomfort. Most of the time, they won't have heartburn, and that's because there is an entity called a silent reflux or laryngopharyngeal reflux, whereby, so this is the esophagus. This leads to the stomach, and acid and a little bit of pepsin, which is an enzyme which helps in digestion of food, might come up and trickle here. So if it trickles here, this is of course the larynx and trachea and lungs. The trachea and the lungs will produce a lot of mucus with a view to neutralize the acid, and that's what the person is clearing all the time. I'm clearing the throat all the time because it's trickling on the voice box or on the vocal cords. The patient might have gravelly voice or hoarseness of voice. It causes spasm of the cricopharyngeal muscles, or also might cause mucosal swelling, and the patient will feel that there is some lump at the back of the throat. The signs the examination is easy by putting a scope down, and you can see a bit of redness in the arytenoid or interarytenoid region, bit of congestion. Treatment: avoid fried and spicy food, watch what you eat, basically vocal hygiene, dietary advice, sleep propped up and to the left side. Sleeping to the left side just relates to the fact the way stomach is placed in your abdomen. If you sleep on the left side, it tends to drain acid by gravity. If you sleep on the right side, the acid tends to track up, basically. That's how it is. Easily treated by proton pump inhibitor twice a day before meals and Gaviscon advanced syrup. Also present in newborns or infants. Up to 2 years, there is a Gaviscon sachet you can give. Gaviscon Advance is given up 12 years onwards. Between 2 and 12 years, you can also give Gaviscon sachet. Gaviscon Advance is only syrup which is licensed in prevention of pepsin reflux. It forms a physical raft, like a physical layer at the top of the gastric content, so that pepsin can't penetrate it, and it is typically taken after the meal, so last thing at night. So at night when you're sleeping, the pepsin can't come out. Likewise, the proton pump inhibitors do taken before meals. So all this is very important. The compliance, I take a long time to explain to the patient because they're not having any heartburn. So if they're not convinced they've not got reflux, they're not going to take the medicine. So it's absolutely crucial to explain to them what they have. I typically give them this leaflet, which is present to download freely. Again, very useful resource for your surgery. I always print them out in the clinic. Is britishvoiceassociation.org.uk, the British Voice Association website. You click on the free resources. There are a whole lot of leaflets, all free to download for patients and for yourself. And the reflux one is the one which I most commonly use, and it actually explains to you how it is. And it's more common than you think because it does not cause any heartburn, so it's much less diagnosed. Earwax. Very common thing, a normal constituent of ear produced by cerebrous gland, dead skin canal secretions. It has a function, it has protect and lubricate ear canal skin and have some antibacteriostatic or antibacterial properties. Normally there is a conveyor belt which you throw the wax out. It doesn't work well always, especially if a person has narrow canal or very hairy ear canals, or if a person uses hearing aid or uses headphones these days, which goes in the ear canal, which physically blocks the clearance. If it happens, if you see someone, simple thing, you're probably doing already. The drug of choice for this, which I recommend to them, is over-the-counter sodium bicarbonate ear drops, 3-4 drops, 3-4 times a day for a couple of weeks. It's important to explain to the patient that the wax might absorb the drops, and the ear might actually become worse with increased blockage and pain because the wax will swell up. So don't worry about it. If it does not clear, if they're using it, if the conveyor belt starts kicking and if it throws it out, well and good. Otherwise, Olive oil or almond oil is also can be used. Microsection of the ears is the gold standard treatment. Traditionally, syringing of the ears used to be done, which is not recommended now. Too many patients I've seen who develop ear infection following syringing, or worse, even perforated eardrum. So microsection of the ear is quite easy to do in clinic, one appointment, and that sorts them out. This is about ear wax. Some people are predisposed to having buildup of wax, in which case I always advise them to, if they ever need a microsection, to you put a sodium bicarbonate ear drops for a week prior to them running up to the appointment, which would help me clear their ears. Glue ears, of course, we know is very, very common. Up to 40% of population at 2 years of age will have glue ear. As they grow older, they slowly grow out of it. The etiopathogenesis, the eustachian tube gets blocked with recurrent upper respiratory tract infection and subsequent vacuum behind the eardrum. If it persists, the hydrostatic pressure in the middle ear blood vessels exceeds the air pressure, and hence the fluid comes out in the form of glue. And if it's because it's stagnant, it can cause hearing loss, speech defects, balance problem, learning difficulty, problems with learning, missing out on learning. Usually, statistically, kids tend to grow out of it by 7 years of age, and that's just because the eustachian tube grows, the postnasal space grows, the adenoid shrinks slowly. Risk factors are under 5 years, males, parental smoking, siblings with otitis media diffusion, recurrent coughs and cold, upper respiratory tract infection, where they pick up bugs in nurseries, or if they have some allergies, hearing loss, earaches, ear infection, speech delay. It can have profound adverse effect in a child's life. There are, of course, if they are not listening to the key worker or the teachers, that might often be perceived as a behavioral change and might trigger investigation for ADHD and autism. So very profound, very important. There are NICE guidelines which outlines the management of glue ears. In general, and speech frequencies, average of it, if there's 25 decibels or persistent 25 decibels or more hearing loss in the better ear, which is persisted for more than 3 months, that requires one from Grommet. Initially, clinical assessment. Apart from clinical assessment, I'd always perform a hearing oil pressure test like tympanogram and audiogram, which would tell me the hearing level. As a conservative management measure, there is an auto vent balloon which is freely available over the counter from Boots or any chemist. The idea is it's like a toy it comes with instruction. With the child try to blow this balloon through their nose. The idea is it's equivalent to performing Valsalva maneuver. If the child is big enough to perform a Valsalva maneuver, like touching the top of the blowing hard 10 times in the morning, 10 times at night for the next 3 months, ask them to. If they can't, then ask them to use auto-vent balloon for the next 2-3 months. Of course, the hearing aid is always an option. In my experience, it's the tolerance is not great in most kids, but if the kid can wear hearing aids or a soft band, yes, by all means. If so, as per NICE guidelines, if for 3 months the hearing loss 25 decibels or worse in the better hearing ear, averaged at 3 speech frequencies persist, then they would be suitable for a hearing aid. In real experience, and it's a discussion it's a shared decision making, and sometimes even if it is less than 25 decibels, if it is having a profound adverse effect, if it's a trigger investigation for ADHD or child has been referred to for autistic spectrum disorder, I often put the hearing the grommets, and it often makes a massive difference to their outcome and speech and learning and everything. Infection, otitis externa is rare. Treatment is, simple term is oral toilet, like microsection of the ears and eardrops. Silodex eardrops are now most drug of is drops of choice because it's not ototoxic, so ciprofloxacin and dexamethasone. You can also give ear calm spray like acetic acid, which prevents the growth of bacteria as well. In addition, for a week or so, it's over the counter. We're talking about now tympanic membrane perforation. Most will heal themselves now. Again, usually it starts off with a glue urine child and the glue stagnates, and if it's not treated, it can get infected. The pus will put pressure on the tympanic membrane to perforate, and the ear will discharge, and that's how the child is relieved of the symptom. Eardrum will be sealed up, and then that's how they get these scarring or sclerotic patches. If it persists, they can be left, or if it happens too often, they can be left with a tympanic membrane perforation. If it does not heal, the options are, you can leave it as it is if it's not causing any problem. The indication for treating it by operation called tympanoplasty or laryngoplasty is if it causes recurrent ear infection, because the aim would be to give patient a waterproof ear, because hang on, the light is on. Yeah, so the aim would be to give them a waterproof ear. Usually, hearing gain, if any, is bonus, but that's not the cause for doing a laryngoplasty. So this is, as I was just mentioning about, so in this picture, in the left lower picture, you can see a bit of air bubbles, bit of glue behind the eardrum. You can just see a streak of blood vessel running across the tympanic membrane. So this is when the glue is collected and it stagnates and it stays there. If it's not treated, then it's beginning to get infected. This is the glue ear. If it gets infected, it can cause collection of pus in the middle ear. It can cause high temperature, severe excruciating pain. This is an ear canal typical, showing the pus bulging the eardrum with the impending ear perforation, because eventually the eardrum will give way, leading to discharge of pus and resolution of patient symptom and relief from symptom and temperature. Treatment: antibiotic, painkillers. If the ear patient is still symptomatic and if it is not discharged, then you, under general anesthetic, you can make a cut here, let the pus out, and put a grommet in with some ear drops. Clinical features. There is often a preceding history of upper respiratory tract infection, highest incidence in 3 to 7 years. General symptoms: irritability, poor feeding, fever, pain, deafness, mucopurulent otorrhea, as you can imagine from listening to the history of the pathogenesis of ASM. Examination, we've already seen how it would look. Preauricular sinus, again a developmental sinus. Indicate if it's not causing any problem, you can just leave it. Often, if the child comes to see you, that's because it's causing some discharge, some smelly discharge, that the parents want it out. Quite often, there could be preauricular cyst rather than sinus, where it causes a painful swelling, which eventually bursts and causes some discharge. So if it continues to be a problem, then you can excise it by a simple operation. Noses, we're going to talk a little bit about noses. Polyps are very uncommon. If you see a polyp in a child, it's more common in adults, but if you see a polyp in the child, that should trigger off a suspicion of some sort of hereditary problem like cystic fibrosis, some sort of or Cartagena syndrome like immotile cilia syndrome, because it's not very common in kids. And likewise, there's very limited role for sinus surgery in children. This, as we know, is a complication of sinusitis in children called periorbital cellulitis, in which a sinus infection can either through a septic thrombi through the sinus can go inside the eye and cause problems. Treatment is urgent presentation to A&E with IV antibiotics, nasal drops, and a CT scan, analgesia. If the CT scan shows any abscess, that will need to be tried. So we often see these cases at Queen's presenting to A&E. Quite often, there's only cellulitis, and they resolve with conservative measures. And a close observation is recommended with frequent visual acuity recording in the notes, just to make sure that this vision is not deteriorating. Foreign bodies, all of us know. I mean, in a GP surgery, you're unlikely to see any foreign body of pharynx or airway. I suppose you're more likely to see a foreign body in the ear or nose. I mean, for God's sake, if a child presents with a battery, that's absolute emergency. They should be rushed to the nearest accidental emergency. And that, as we know, is because of the chances of battery leakage causing alkaline damage and alkaline batteries. This alkaline stuff is very abrasive. It just cuts through. I've seen children die with it in one of the places I worked before, not here. Yeah, that. So battery is absolute emergency. The other foreign body can be classified as organic or non-organic. Organic like seeds, orange pips and stuff. And the relevance is that they tend to absorb moisture. Let's say if they're in the nose, they would tend to swell up, and so that's why they need to be removed relatively urgently. If someone is present to you with a bead in the ear canal like this can be sent to clinic, let's say the next day or so. So it needs to be removed, but there's not that much of emergency. This is a coin in the cricopharynx in the esophagus, of course, with the X-ray, and we do an X-ray and then remove it if necessary. Interestingly, for foreign body in the esophagus, in some of the A&Es, not everywhere, they keep a metal detector. And as the kid come in with a history, of course, you can always do an X-ray, but even before that, one of the simple tests you could do is pass the metal detector here. And according to the published literature, if it beeps above your xiphisternum, that means there is a coin and it's still in the esophagus. If it beeps below the xiphisternum, that means there was a coin which has gone down in the stomach and it could just discharge that. So that's quite interesting. Right. Any questions? Thank you very much for listening, and I hope that was enjoyable. And if there are any questions, I'm happy to take the questions.
Okay, there was no question in the chat box, but what I would say to people is if you've got any question, this would be a good opportunity to unmute yourself and ask those questions before we round up. Thank you.
Hi, I've got a question, please.
Yes, please.
First of all, thank you so much. That was very helpful. I'm one of the GP ST1s. You mentioned to consider steroids in, I guess, severe tonsillitis, not requiring admission, or if they're well. Is there a dose, duration, dosage? Is it just
Yeah,
prednisone?
absolutely. I mean, it's a difficult one because in a young child, it's probably better just to try them on antibiotics, Difflam spray, make sure they have plenty of pain control. I'm sure, you prescribe Difflam spray or gargles, uh, analgesia, full dose, and antibiotic. One of the things I would say, I think in BNF, because quite often when we see the patient, they are taking, let's say, a lower dose of antibiotic first, which I suppose is the protocol in the BNF, which is fine. But I suppose by the time cases filter out to us, they're already severe and they would have had a low dose. So all I would say is consider giving them high dose of antibiotics. We do give steroids in hospital, but yeah, in a young children, I probably won't give steroids in the primary care. In a bigger child, you can try. Let's say in a teenager, you could try like low dose, like a 5 milligram prednisolone or something like that. But yeah, I think we did that in the first lockdown, and initially. But now we're doing it as we would treat them normally. And by the way, by the time they come to hospital, they are severe and they do get steroids. But I'm not sure in the I would use your own discretion in the primary care.
Thank you very much.
Thank you. There's also another question. I don't know if you can see. It says, for tongue tie, how can we make urgent referral as currently NHS referral waiting time are long for ENT?
Absolutely, and thanks for this question. I'm one of the recognized tongue tie practitioner. There is an Association of Tongue Tie Practitioner (ATP) website, and basically this is a big problem. I see a lot of patients, like in the last few months, I've seen more than 60 patients. The parents don't know what to do. They can't have tongue tie, and it has a profound effect on feeding and thriving. There are two pathways. From my perspective, I'm the pediatric guy at Queens, and there is a referral pathway on NHS. So the midwives or the local GP would refer the patients to me, and I try and see them because they're so urgent and because it has profound adverse effect on the child. I try and see them in my NHS pediatric clinic. Obviously, as you rightly said, in the current pandemic, it's difficult and there are only limited slots. Of course, I provide this service in the private sector as well. So, but yeah, try the NHS first.
There's also another question for you.
Yeah, I would accept a referral to a GP, like a referral letter. Yeah. Next question. Can we email to your secretary if a child needs to see an urgently choosing book clinic? Yes. So again, you can email to me or my secretary. I'm very happy. And what I do is I screen the referral whether it's urgent or routine. If it's routine, I ask her to book a next available clinic appointment. Of course, it's a bit frustrating for me as well because out of that, it's out of my hand. Pediatric clinic are being arranged as and when at the moment, and I do accept that there are not enough pediatric slots. Being a pediatric lead at Queens, we did an initiative which is actually in which we did three Super Sundays in which we saw more than 300-400 pediatric referrals like this, just to so that these kids are seen. And I believe some of the more clinics are coming up, but yeah, if this is a limitation, and again, one of the downsides, one of the problems, challenges we face with pediatric clinics is because with the kid, a parent is allowed, so there is more footfall. So we were only allowed to see less number of kids because the number of people, the number of footfall will be double the adults. So adult can come alone, but child can't. So there was a limited, and of course there are challenges because they need to have a proper pediatric area, and so that's why we did this Super Sunday. So I believe a couple more are coming up, but yeah, I mean, refer to them and we'll try our very best within the limitations of the surveys what we can do.
I don't think do we have any more questions? Because I know it's 1:30 now. We need to kind of wrap up. If there are no questions, we're going to close today's session. I just want to say another big thank you to Mr. Jan for today's session. Today's presentation, the recording will be made available on BHR CPN website, and you will be receiving an email either today or tomorrow for you to complete the evaluation form as well, so you can receive your certificate of attendance as well, and a copy of the presentation will also be attached. Thank you once again, and we hope you find today's session useful and beneficial as well. Thank you, everyone.
Thank you very much. It was a pleasure, and thank you, Bola, once again for organizing this.